Very poor prognosis. So obviously, we have a very high drive pressure of 20. That's well above the 15. We're whiteout on the CT scan. So the on the CT scan, you got definitely the left dorsal, mid dorsal, possibly mid ventral. You start having aeration, but the left side is quite attained. So we'll look at the CT scan and we'll kind of get an idea of how this tomography compares to the CT scan. So over here, I just wanted to compare the tomography image with the electrical impedance tomography compared to the CT scan. As you can see where the two arrows in red are pointing to, we have on the CT scan that whited out area where no ventilation is occurring. And you see that correlated with that purple impedance that's appearing on the bottom left dorsal region. This purple area that's appearing in the level 4 region, which correlates very well with the CT scan, shows that there's a significant amount of fluid buildup there due to the pneumonia. Looking at the radiologist's interpretation, there's also a certain amount of an effusion there. So it's a combined effusion as well as the exudate that is being captured with the negative impedance values interpreted here as purple. The black region of the CT scan indicates the area of aeration. And again, that correlates very well with the EIT's correlation appearing where ventilation is in blue. Quite attained. So we'll look at the CT scan and we'll kind of get an idea of how this tomography compares to the CT scan tomography. You see on inspiration here, there's good distribution of ventilation overall here. And sometimes on expiration, notice it goes down. So they're actually, as they're expiring, the air is going down to the left region. So there is a possibility of air going there due to the exudate, due to the amount of fluid accumulated due to pneumonia. This sometimes can appear purple. Sometimes if it's in the middle, it's the mediastinum. If you have two purples on each side, that might be the diaphragm. You need to put the belt a little bit higher. And if you have significant pleural effusions, an indicator could be this purple impedance that shows up. Okay, so at this point we also did a incremental Peep study in an attempt to recruit that left dorsal region. We went from 10 to 20 and then from 20 back down to 10. The patient showed no further recruitment of the desired area with higher Peeps. Although we did occasionally see in the left dorsal region where you see the purple negative impedance that on expiration sometimes ventilation did occur in that area in a delayed fashion. So since there is a potential for distribution of ventilation in that area, we're going to try an Aprv trial to see if we can recruit more with a longer T-high. If the pressure itself with a smaller T, the inspiratory time didn't do the trick, perhaps a more sustained pressure that we can achieve with Aprv could open up potentially that area. So it's worth a trial. So with the saturation that is at 75% on an FiO2 of 100, the doctors asked that the Peep as a last-ditch effort be increased to 20. This is in correlation to the ARDS net that titrates Peep often in relation to FiO2 requirements. Thank goodness we had the Palma Vista where we could increase the Peeps and at least get some feedback to give us more confidence where to set that Peep. Is the person going to respond to higher Peeps? What's going to happen with the higher Peeps in relation to compliance? Will it open up that lower region? We really don't know. We're almost going blindly, increasing the Peep to such a high level without getting any real feedback besides plateau pressures, oxygen saturations, compliance, etc. The electrical impedance tomography really gives us eyes into the lung, inside the lung. How is the air, the tidal volume that we are delivering, how is that dynamically changing based on the manipulation and various maneuvers that we're doing on the ventilator? So I'm going to show you a couple of the studies, the Peep studies, based on that's based on regional compliance values. So let's take a look at that. So this is the result of the custom analysis determining regional compliance. As you can see on the bottom, there is the RVD ratio, which shows residual volume delays. So this is instabilities within the lungs, possible cyclical opening and closing. So we really don't want to see any of that yellow apparent ideally. So when yellow appears or worsens, that's definitely an issue. Here we see compliance win, which show up regionally somewhere in blue if there was improvements in compliance in that region. As you can see, pretty much the whole thing is orange. And on the bottom, you'll see Peep increments of 10, 12, 14, 18, right up to 20, and going from 20 back to 10. So we did a incremental as a way of, first of all, finding regional compliance and best Peep, and also an attempt with the higher Peeps to evaluate if there's any potential of opening up that left dorsal region. We see a significant increase in the loss of compliance. We don't see any win in compliance very much. We see 19, 27, 36, up to 52% loss in compliance with a Peep of 20, and we see the same trend occurring when we go from 20 to 10. So at this point, the lowest compliance, the least loss of compliance, or the best compliance, would be somewhere in the region of 10, and we didn't even test 6 or 8, which could also maybe potentially be even better than 10. Knowing that the optimal Peep, at least when comparing 20 to 10 and 10 to 20, and the incremental and decremental Peeps, we saw that 10 was optimal. So we went lower to 8 and 7 quickly just to test out the optimal Peep. And as you can see, with 12 and 10, there's still a significant amount of residual volume delay appearing in yellow. So Peeps of 12 and 10 are making the lung actually more unstable. We see that the compliance win shown in blue that begins increasing compared to 10 to 8. We have a 19% increase in the compliance in the region that we can see in the line of the 8, and we see an even bigger improvement of compliance with 27% at a Peep of 7. So the optimal Peep would be somewhere between 8 and 7 would be acceptable. So the most important is to continue to redo multiple tests to make sure that there's a certain amount of reproducibility in the results. So I'm just looking briefly on Aprv. We have a P high that is 30. There was a pressure control that was set at 30 previously. He's still making efforts, but I just want to quickly look with a stretch T high of 5. And if there's an improvement in the left dorsal region distribution, then maybe I'll ask him to paralyze him, sedate him more, and just let us take control of the lung. If I do switch into that, then I would be titrating the P high based on regional compliance, and I do that with the Peep trial or the custom analysis. All right, so region 4, this issue, we have 5 to 10, 5 before. And we have about 6 now. Let's see a couple of breaths. Does manage to open it up sometimes here and hold it. That could possibly be beneficial over time, like you see here. Maybe I'm going to put a full screen. Just wait for the next drop. So it could open up over time. It's not doing much for the oxygenation now. Okay, that's it. I'm not gonna keep the patient on APRV, but I might talk to the doctor and ask if we paralyze him and try APRV. Maybe this could work a little bit more. It's worth a trial. APRV, it takes some time. Sometimes you might get the benefit that's sustained there, like we're seeing here, but it might take a couple of hours. Almost a whole shift.